Hey everybody, welcome back to the You Are Not Broken podcast. Today we are doing a Ishwish 2026 review. That is the topic of this. I'm also live on Instagram for people who are in the moment. Hi, welcome to 2026. Busy, things are happening. Not as crazy as 2025. That was nuts, but happy to be in 2026 and setting the year off right. I've been to Los Angeles and the surrounding Los Angeles area 3 times so far in 2026, which is a bit above average, but direct flights would be nice. Bellingham Airport. So before we go into the Ishwish annual meeting 2026, I'm going to do some housekeeping things you guys need to know. So much of my podcasts are me interviewing people that I really love, like me just riffing and answering questions and like to get you guys all caught up on the happenings. So we're going to run through some housekeeping items first. First of all, Ishwish annual meeting 2027 is going to be in February 2027, and it's going to be in Vancouver, Canada, which is fantastic. So I'm obviously there because I live in the Pacific Northwest and it's an easy drive for me. And I think you guys should come too. So for people who've never been to Ishwish, 2 things to consider. First of all, if people who don't know, Ishwish is the International Society for the Study of Women's Sexual Health, started by a urologist. Fantastic organization, very multidisciplinary. And like you go there and like women's testosterone is normalized. Like you don't have to explain yourself. You're not fringy. You're not weird. You don't have to justify yourself. You just know. You're surrounded by people who know that female dose testosterone is a thing and women's orgasms are important. Like you don't have to explain yourself, which is refreshing. So for people who are interested, if you're new to the whole, like I want to know more about female sexual health, et cetera, I would recommend their fall course, which is usually held in Arizona. It's usually in November. That is a didactic classroom style. They have hands-on vulvar exams. That's your intro to do. The annual meeting is more like research, what's new in the field, thought leadership, what's up and coming. That said, if you can't make it to Arizona for the fall course, the beginning, so like the day to 2 days before the Ishwish meeting is like intro stuff. So it's like intro to female sexual health. I think they did hormones this year. So they do have intro sessions for people who kind of want to get the baseline, because otherwise you're kind of thrown into like academic style language. And if you don't understand the nuts and bolts and the bread and butter first, it might be a little like, how is this practical and relevant, right, to like your day-to-day clinical practice? So I would certainly, if you're a beginner, do the fall course. I think I did the fall course 2 or 3 times before I went to an annual meeting. So that's my recommendation. That's what I did. And I'm glad I did it because you're kind of drinking out of a fire hose, doing like abstracts, like it's an academic meeting, the annual meeting. So if you do the annual meeting and you haven't done the fall course yet, that's fine. They let you in, but I would recommend paying for the additional like beginner intro class days that they have at the front end of the conference. So see you next year in Vancouver for Ishwish annual meeting 2027. Next, housekeeping, the M Factor 2.0 is coming out. For people who don't know, M Factor, the first M Factor was on PBS about 2 years ago about menopause. And this is the sequel, which is actually a prequel because it's perimenopause, whereas the M Factor was menopause. And it's very well done. I have seen it 4 times already, 4 times. And it is going to be out on PBS March 18th. And there are multiple tours going on in major metropolitan cities. I just did the Seattle one at the Nordic Museum. I did that the night before I flew to Los Angeles to do the ISSWSH Conference. So I went down to Seattle, did the M Factor Seattle premiere, did an hour-long Q&A, and then flew to Long Beach. So Bellingham, Washington, I'm hosting the March 22nd. That's a Sunday. Doors open at 1. Event starts at 2. We're going to do a documentary premiere. The documentary is only an hour long because PBS documentaries are an hour long. And then we're going to do an hour Q&A, Casperson Dog and Pony Show with 2 special guests that have agreed to be on stage with me. So I'm very excited about that. That's March 22nd. Tickets will be available. By the time this podcast is live, the tickets should be up. So for the first one we did 2 years ago, we sold out the first floor of the theater, and we are going to do the same. So don't delay on getting your tickets. M Factor 2.0 with special guest, me, and 2 other people. All right, number 3. If you've been living under a rock, I have a vibrator now. which I don't have to show and tell you right now. It is made with my good friend Laura Pack, who founded Elixir Play. It's an amazing, high quality, female curated vibrator company based out of Sydney, Australia. And we just released the Explorer, which sold out in like 2 days because it's awesome. And it's just very unique. If you follow me on Instagram, you'll see some reels showing that. So if you go to elixirplay.com and go to the vibrators, Explorer is my vibrator, and it will be, you can pre-order it now. We'll probably be caught up with the pre-orders and the backlog from being sold out March and April. So to get yours, it's awesome. It's focused for the vulva because underneath or inside the labia minora is the clitoris. Clitoris is like a wishbone, right? It's not just the tip of the iceberg that you see. And really, there's not a lot on the market to stimulate the vulva. So this is created for the midlife woman, maybe pain with penetration, maybe history of trauma, maybe doesn't know what arousal could possibly be, trouble with orgasm. Really stimulating the vulva is why this was created. So non-penetrative and to truly bring in blood flow to the entire clitoral vulvar complex. The discount code for the vibrator is not broken 20. So go to the website, discount code not broken 20 to get your pre-order because it's currently sold out. All right, next is to thank the leadership of Ishwish. These 3 people I wanted to shout out the most to. Many, many amazing leaders at Ishwish, but I want to shout out to Dr. Sarah Signa, Dr. Sarah Signa, and then Heather and Tammy. You know who you are. You are amazing. And I don't think Ishwish would be Ishwish without you guys. And you guys are smart. You guys are professional. You guys take feedback like a champ and help run the educational committee of a pretty big organization. And my life is better with you in it. So Dr. Tammy Rowan, Dr. Heather Quayle, Dr. Sarah Signa are all amazing up and coming leaders. And Dr. Samina Rahman, also gynecologist out of Chicago. Check her out. If you need a sex med hormone specialist in Chicago, go see Dr. Samina Rahman. She's amazing. All right. The next thing I want to talk about is my sex ed course that I did with Commune. It's now up on the Commune's website. You can actually get to it through my website too if you go under courses. And it's a very well done professional course all about adult sex ed, things you were never taught. And it's doing really well. People are really liking it. So check out my adult sex ed course filmed with Commune. It's on their website if you're a Commune member, and you can get to it via my website as well. Check it out. Also under courses on my website, I just did an alcohol one. So that's going to be available for purchase pretty soon. Basically talking about how do you become a person who doesn't drink alcohol in a society that worships alcohol and normalizes alcohol. So showed some papers about it. I was getting feisty at the end of this alcohol webinar too, because people are like, so can we just replace it with marijuana? And I'm like clapping at the screen. I'm like, you are not listening to me. The point is to not numb your life. The point is to not put drugs in your system. The point is to become the person who doesn't need to put drugs in your system. The point is to become the person who feels the feelings and doesn't numb yourself. So I was feisty at the end. I'm like, you are not listening to me. So alcohol webinar, a little off topic from what I usually talk about. But if you go to my website, kellycaspersonmd.com, and you go to the drop-down menu courses, alcohol one is not up there yet, but it'll be coming soon along with other courses on there. So many people on Instagram, I see this too. They ask all the time about, am I too late for hormones? Is it too late for hormones? I have a course called, Is It Too Late for Hormones? Go listen to it. It'll be very helpful. It basically breaks down the data on safety of estrogen as we get older. And ultimately, it is a risk-benefit conversation with a trained clinician. I learned something at Ishwish this week, which is kind of embarrassing not to know this, but I don't think most clinicians know this. And so if most clinicians don't know this, most other people don't know this. The actual definition of evidence-based medicine. Shout out to Dr. Corinne Men for pointing this out. I'm sure we learned this in medical school at some point, but the actual definition, and you can Google fact check me on this, the actual definition of evidence-based medicine is 3 things. Number 1, data, science, published literature. Number 2, experience of the clinician. Number 3, wishes and informed consent and input from the patient. All 3 things. So many people think of informed consent as what does the data say? And they also will take that and they'll be like, what do randomized placebo-controlled trials say? That's not informed consent. That's what evidence-based medicine is. And we're like, no, evidence-based medicine is actually data, expertise of the clinician and discussion with the patient on what their risk benefits and wants and goals are. So I just think it's incredibly powerful to reframe actually what is evidence-based medicine, because I think when people, especially on the internet, say, we use evidence-based medicine, blah, blah, blah. It's like, back up. Do you actually know what the definition of evidence-based medicine is? So shout out to Dr. Corinne Men. What are we working on right now on an advocacy level? Two things, two of the biggest things. Number one, getting vaginal estrogen over the counter. Very exciting. We'll see where this goes. Marty McCary was just talking about this on CNBC last week. They're listening, which is fantastic. Female dosed testosterone, certainly high up on our list. That's probably the biggest lift because of the cost of getting a pharma and studies, et cetera, et cetera. And then I think we're going to deregulate testosterone so it's not a scheduled 2 or 3 medication to make access easier and to correct the stigma on how safe it actually is and the proper regulations to reflect its actual safety when used in normal physiologic doses. All right. Somebody had asked, what's a good book for postmenopause? I see a lot of books for perimenopause and menopause, but what's a good book for postmenopause? To which I replied, menopause is one day. Every day after that one day of no periods for a year is postmenopause. So when you see a book written for menopause, it's the same as any book written for postmenopause. People just don't know the definition. So I say, of course, get my book, The Menopause Moment, because that covers perimenopause, the day of menopause, and all the days after menopause, which we kind of call menopause, but also postmenopause. So wanted to clear up that definition for the person who's like, where's all the books for postmenopause? I'm like, it's the exact same thing and the same books as the menopause books. All right. Somebody had asked a really great question, when to switch from a telehealth to a more like expert clinic for hormone needs. And I love telehealth. We need telehealth. I call telehealth mass transit. Like all cities need mass transit. We need this. We can't, like the math on this, you guys, there's 1 million physicians and 80 million women over the age of 40. Like we need mass transit, but sometimes you need to get in a car and go down a road that mass transit doesn't go down, right? And so I can't say specifically, this would actually be a really great Substack. Maybe it'd be a great podcast episode of like, what are the 5 reasons to switch from telehealth to a clinic expertise? I think you will know. Like, I think it's an individual. If you're like, I'm not getting my needs met with mass transit, but by and large, like mass transit is absolutely necessary and can help the large majority of people. It's just some people need, they've got special healthcare concerns. They want a deeper relationship. They want, in-person care. They want, they need stuff that's not typical as far as hormones go. So certainly it's the minority, but it's a great question. And I should probably do some more work on that. So God bless all the telehealth. They work for the gross majority of people. I'm so glad they exist because we are not going to get out of this undertreating problem without them. But at some point, some people do need to make the decision if they want to seek specialty expertise care, which specialty expertise care can't take care of 80 million women, right? There's just not enough. My new patient visits are an hour and a half long. I can't 80 million women that, right? So it's certainly like what you're looking for. All right. Up and coming. I have a very exciting stuff on the podcast coming as far as heated rivalry goes. So if you know, you know. If you don't know, I've just prepared you. Watch it. HBO Max is like $10.40 a month. You can I literally binge it it's 6 episodes. I binged it in one night, stayed up very late, and that's not good for you. But I highly recommend it. So if you haven't watched Heated Rivalry yet and you're curious, it is the number 2 streaming television show on the planet. It's huge. So we've got some exciting things coming up on the podcast in regards to Heated Rivalry. I won't share any further things, but I just gave you a warning. If you want to be in the know when we drop some cool things on the podcast, maybe you want to watch it. Maybe you want to get obsessed. Maybe you want to live rent-free in your brain. That's what it does. But truthfully, heterosexual women are what's driving the success of this television show, and there's a lot to analyze. The series on HBO is called Heated Rivalry. You've been warned. It is erotica. It's not porn. It's erotica. There's a difference. I recommend my new vibrator. My vibrator plus Heated Rivalry, heart-shaped emoji. All right. I think that's all my pre-courses. So now what I'm going to do is I'm just going to run through like the notes that I took at the ISSWSH annual meeting. And this is not comprehensive. I will leave out people's names. I apologize in advance if I get anything wrong. This is just like Dr. Casperson taking notes at the ISSWSH Conference. So when we were there, the FDA actually had announced that officially the boxed warning has been changed on 6 estrogen products. So that was a very exciting event that happened when we were at ISSWSH. I had a vibrator party for my Explorer, which was awesome. I had some of my closest friends come to a cafe and we had a vibrator party, and nothing like coffee in the morning with vibrators. So if you are on my Instagram, you can see some reels that I did about that. It was very awesome. There was some data on sex after breast cancer. About 1/2 of breast cancer survivors have issues with their sexuality, whether that's pain, decreased arousal, lubrication. Chemotherapy is associated with worse sexual satisfaction after breast cancer, and your sexual dysfunction is worse if you were younger at age of diagnosis, maybe because they had farther to drop as far as, higher functioning sexuality before treatment, but certainly younger age at diagnosis is a risk factor for worse sexual dysfunction after breast cancer. Shout out to all of the medical students who presented. It is intimidating. I was there. We've all been medical students. It is a great opportunity, certainly for your CV and your resume and just experience talking. I did it too when I was a med student. Huge honor, but scary as fuck. So shout out to all the med students who were there and who presented, because you're amazing and you're brave. And I want you to know that we saw you and we were cheering you on. All right. So, and shout out to Ishwish for having medical students present, which is super, super awesome. All right. There was a talk on the purity culture of sexual shame. There was some research that had come out of Texas. That was super interesting. And I found out when we were at Ishwish that my first book, You Are Not Broken, Stop Shoulding All Over Your Sex Life, will be translated into Spanish July 2026. That'll be Spain, July 2026. And then will be released in the US and Mexico 3 months later. So what's that, October 2026? So I'm super excited to see that cover. It's going to be super great. Huge, huge need for the Spanish-speaking community. And that was a super exciting thing that happened during Ishwish. Was amazing. Between the vibrator parties, the FDA, officially having the box warning off of 6 estrogen products, You Are Not Broken being translated into Spanish, seeing all my friends, and basically just I'm just hang out at Ishwish now. It's super fun. Okay. They did some research. They did a presentation on research on clinicians who recommend, quote, have a glass of wine, quote, for people who come in with sexual health issues. And then the clinician says, have a glass of wine. So it's a very gendered thing to say. Clinicians don't tend to say that to men. It's much more gendered that they tend to say it to women. We don't tell a man with erectile dysfunction to take a shot of alcohol as a solution. And they researched, why do you say this? Why do you say have a glass of wine? And what they found is that this persists because of a belief that it will help. 36% of people thought it would help people relax. 18% don't know what else to say. 11% says that it's an accessible thing to recommend to people. And the shocking thing of this presentation was that the more that the clinicians were trained in sexual health, the more likely they were to say have a glass of wine. And they had some theories on why, but they didn't actually look into that to my knowledge, but that was a very interesting discussion. They did some presentations on oral sildenafil. So sildenafil brand name is Viagra. Again, this is a women's sexual health conference. So we looked at female sexual health, and it varies. So oral sildenafil varies in efficacy. It decreases orgasm latency, so the time it takes to orgasm, and it can increase orgasm intensity. And the doses for this that the women were taking was 50 milligrams. They do have data that it helps in type 1 diabetes. So sildenafil is a blood flow medication. That's how it helps erections. More blood flow into the penis, more blood flow into the clitoris. And they're also coming out with a product. It's DARE, D-A-R-E Pharma. It's coming out with a topical sildenafil. Some people, you might hear that there's a variation of that you can get compounded called Scream Cream, but DARE Pharma is actually doing a sildenafil topical for females. It's still a prescription, but I think the website is up on that. We probably Google DARE Pharmaceuticals topical sildenafil will probably come up. They were looking at the role of the placebo, right? So we know placebo is huge in the male Viagra studies. So they were looking at women in their 20s with no sexual dysfunction. If they suspected they got Viagra, they did better. Right. So the data is kind of all over the place on this, but what they did show was that if you take Viagra daily, kind of like men take Cialis daily, like if it's a daily medication, they tend to do better than taking Viagra on demand, like an hour before sexual activity. There's actually this is more male data, but there's data that sildenafil and these blood flow drugs, actually, people who take them have a lower risk of dementia, likely because blood flow to the brain, right? So these medications are cheap. They are blood flow medications. There is a signal towards less dementia. So in the longevity world, people are like, Viagra, as far as brain health goes, and it helps orgasm and erections. So they did some studies looking at sildenafil and oral testosterone combined. It was oral testosterone, 0.5 milligrams sublingual and 50 milligrams of the PDE5 inhibitors. And the outcome was satisfying sexual events. Testosterone seemed to increase the sensitivity to sexual cues. So you're more like going to pick up on sexual cues. Even we see this a lot when we give women testosterone. It's not that like you become this like seeking horny person where you're seeking out sex, but you're more receptive. Like your responsive desire is more supported when you're on testosterone. So that'll be interesting to see more combo research looking at the combo of testosterone and sildenafil. So again, they act in different ways, but they seem to be complementary in supporting sexual health. Dr. Rachel Rubin did a talk on GSM guidelines for anybody living under a rock or new to me. The American Urologic Association in 2025 came out with genital urinary syndrome of menopause guidelines, free online. Love it. All right. Amazing talk by Dr. James Faust, a PhD. It takes two to tango. It was all about estrogen and testosterone. One of the best things that he said, I wrote it down, penises are prolapsed clitorises. Seriously. Like, just make me a t-shirt. Testosterone's conversion to estrogen makes the male brain. Estradiol makes dopamine. Androgens, which are testosterones and androgen, increases your serotonin and increases your dopamine. So again, going back, these are brain neurochemicals. And he was talking about like rat studies that were done in like 1937. So in 1937, 90 years ago, 89 years ago, they took female rats, they removed their ovaries, and they give them testosterone, and they showed that testosterone restored their gonadal tissue. Amazing. Paper from 1985 from Sherwin, estrogen and testosterone in surgical menopause. Testosterone helped arousal and desire. Talking about how long it can take for testosterone to work. Sublingual testosterone takes about 4.5 hours to kick in, and this is how long gene transcription in cells takes from the hormone being on the cell surface to going inside the cell to actually transcribing a gene into a protein takes about 4.5 hours. Testosterone seems to help with arousal desire concordance. What does that mean? It means when your pelvis is aroused, you are desiring of sex. So in a man, stereotypically, if you have an erection, he's interested in sex because he has arousal, which is the erection, and then he has desire. Women, it's not as tightly linked. You can have blood flow in the pelvis and not be desirous of sex, but testosterone seems to cause arousal desire concordance or more matching. Satisfying sexual events go up when you combine testosterone with sildenafil. Androgens make nitric oxide and prevent dopamine uptake. So there's more dopamine around in the brain. And he talked about using estrogen and testosterone so that desire and arousal can co-occur in response to sexual cues. So you still need to put yourself in a sexual context, people. Many podcast episodes on that. Hormone, then he said, hormones set the stage. Your experience writes the play. I love that. Estrogen and testosterone increases mood and energy. Testosterone augments the effects of estradiol and PDE5 inhibitors. So they all work together, my friends. Everybody's like, can we just take one? Sure. They're all like players on the same team, which is kind of cool. Another talk about sexual education is social change. Sexual health survivors should not be responsible for stopping the abuse. We need our leaders to step up better on this. Sexual education decreases childhood risk of sexual abuse. Sex education decreases intimate partner violence. Sex education decreases gender-based violence, and sex ed decreases the acceptance of misinformation. So again, see also, I did an adult sex ed course on commune. Go watch it. It's very useful. You'll learn a lot, I promise you. Comprehensive sex ed, the first step is just start talking about sex. You will not die. I promise you, you will not die. It's very good. Comprehensive sex education is a tool for equity and well-being. By grade 11, which is age 16 to 17, 75% of Canadian high school students will engage in fondling, 43% in intercourse, and sexual dysfunction is already present in some people by their teenage years. And somebody asked a really good question about that. They're like, how do you know it's sexual dysfunction versus you're just inexperienced at sex? And they were like, I don't think we know the difference between those things right now. And this is Canadian research. 35 to 40% of teens already had experienced at least one type of trauma in their life. Childhood adversity increases the risk of adult sexual dysfunction. Sexual abuse is associated with negative sexual outcomes in cross-sectional studies of women. It's not healthy, very harmful. Stop harming humans, people. I'm looking at you, men. This is not just me being biased. This is the data. Men, not all men, we know. Okay. Rates of childhood maltreatment by age 14 to 15 are very high. Again, this is looking at some Canadian data. Increased emotional abuse predicts sexual dysfunction in the future, and it keeps getting worse. And you also have more problems with orgasm. 56% of girls reported psychological violence. 20% of teens report physical violence. 9% of teens report sexual violence. This is, again, Canadian data that was presented. Then there was a talk on female genital mutilation, also known as cutting. 230 million girls and women in the world, about 500,000 in the United States, usually performed before the age of 15. Then there was a talk on Black women's sexual function called they talked about superwoman schema, an obligation to manifest strength, or resistance to vulnerability, a drive to succeed with limited resources, obligation to support and help others. There's a maternal modeling of the superwoman schema. The obligation to help others is passed down from generation to generation, and the suppression of your emotions is modeled in this culture. So again, I don't mean to overgeneralize. I'm merely talking about some very awesome talks at the ISSWSH annual meeting. They're talking about faking orgasms and that women do this for many reasons: to suppress emotions of disappointment and frustration, to protect the partner's ego. The superwoman schema, women tend to have lower sexual refusal skills, self-silencing of sexual wants, and minimizing of pain. There's a talk on post-SSRI, which are antidepressants, sexual dysfunction, especially when started early in adolescence. They could have more sexual dysfunction. Stay tuned on my podcast in the next upcoming months. I don't know when it's going to come out right now. I interviewed Dr. Mark Horowitz, who wrote the book on deprescribing guidelines for antidepressants, benzodiazepines, gabapentinoids, and Z drugs. Fascinating talk. I'm so glad I interviewed him. Fascinating to think about and very touchy still in our society. And we talk about that. We talk about why it's so touchy to talk about this. Somebody had made a comment in one of the talks: some women don't know they have the right to be distressed. That was powerful. That landed for me. Girls partnered with girls have more orgasms than girls partnered with boys. This is more teenage research. And then somebody had said that there are 2 states in America that got A's in sexual health literacy. California was one of them, but I don't think we ever learned what the other one was. For a second, I thought it was Washington State, but I don't actually think it's Washington State. Always good talks about pain at the ISSWSH Conference. Talked about a history of endometriosis, liberal tears, spinal issues, all as a reason for pain with sex. Venous pain, so because of heavy veins and venous congestion in the pelvis, can lead to postcoital pain, heaviness in the pelvis. Symptoms are worse later in the day. Those are all signs of venous pain. I wanted to shout out the Tight-Lipped organization. Great nonprofit helping raise awareness for sexual pain. We talked about the double standards. We're comfortable talking about erectile dysfunction and digital rectal exams for men during Super Bowl ads, but we still don't talk about female sexual pain. Somebody did a talk on clitoral adhesions. 23% of sexually active women have clitoral adhesions. The lysis of clitoral adhesions decreases pain and increases sexual function. And then they kind of quantified it as severe is less than 25% of the glands is exposed. There was a talk about body image, and that body image is an embodied experience, like how you experience your body, right? Very interesting. Then there was a talk about breast cancer treatment. 60% of women who've had mastectomies have post-mastectomy pain syndrome, which is not just a loss of sensation, but it's an actual pain from it. 38% acknowledge complete numbness after their surgery, 57% complete numbness of nipples. And it was more of awareness of the importance of nerve-sparing mastectomies to not just preserve sensation, but to minimize pain from nerves being cut. I talked already about how testosterone for women is normalized at Ishwish. It's just a breath of fresh air. I just love it. There's a talk on restoring body image after cancer care. There is a abstract about creating confidence in clinicians. And I just wonder the role of feedback, right? Like how many people when they're learning new things get feedback after you are like out of school and out of residency? Probably not much. There's a talk about porn. 90% of men use it 1 time a week. Women use porn 2 to 3 times a month. Heterosexual women use the least amount of porn. Male use of porn may lower desire towards partner. Women's use of porn is shown to increase desire towards both the actor of the porn and their partner. See also heated rivalry. Oh my lord. Women are obsessed with these actors. One big question that we were having is who's training the pharmacists with all of the new data on safety of hormones and the fact that you can use vaginal estrogen and systemic estrogen at the same time, and that women produce testosterone and testosterone's normal in women, but women get huge roadblocks at the pharmacy. So I have this question, who is training the pharmacists on this? Like we can't do it all. I know we have amazing pharmacists who follow this podcast, and I know how hard you guys are working to try to make this more equitable and actually up to date 2026 level of like not obstructing women from accessing hormones. So I know you guys are working on it, but it's like, I just heard a lot at Ishwish about how pharmacists are obstructing women's access to prescriptions. So I wrote that down. Porn may leave the partner to feel inadequate even if they had sex that day. Females using porn are then report more lubrication during sex. Females using porn may improve communication. Interesting topics we had. A abstract was presented about menopause being used as a social construct. So it was about how in France, when was this? In the 50s? I don't remember. In France, basically a man had said like menopausal women now can't vote or something because they're no longer women or something like that. So menopause being used against women or to control women. And in that sense, menopause is a social construct. Menopause is still very real biologically, physiologically, but the social construct is because of menopause, you now can't X, Y, and Z, or you are X, Y, and Z, like creating a societal meaning to something that biologically has happened to you. Very interesting. Only 5% of women use porn more than their partner. And again, these are like individual studies. I'm not like quoting like all of the studies in the world. These were just talks that we got. 64.6% of women underestimate their partner's porn use. 19.3% of men underestimate partner porn use. This is heterosexual couples. If women know about porn use, is it positive? Partner's porn use, is it positive to the relationship? If they are to disclose it and discuss it, it can be a positive thing. 35% of people think porn is infidelity. There is such a thing as pornographic jealousy, that the relationship could be threatened, self-esteem can be threatened, or somebody might view masturbation as disgusting and they have not communicated that with their partner. Cisgender women had the most porn jealousy. Then there was an interesting talk about camming, which is like live action erotica, that it's not passive. It's connecting with somebody. There's an exchange of money. So are these relational? Are they transactional? Or are they both? That was a very thought-provoking talk. Is camming cheating or a boundary violation? Very interesting. Online intimacy may disrupt real-world relationships. Data shows people are developing relational bonds with camming, not so with porn, right? So porn is viewing something that's been created. Camming is interacting with somebody sexually, but you don't have like an in-person relationship with them. Then there was a talk about cancer and hormones. They reviewed the soft and text trials, which are long-term follow-ups looking at aromatase inhibitors with the goal of cutting back on people who don't actually need aromatase inhibitors for as long because of the minimal gains in survival versus a more high-risk person with lymph nodes or a higher stage that is going to benefit from a longer aromatase inhibitor use, and using the soft and text trials to try to help see, like, let's not overuse these medications because they do have significant side effects that can cause harm. Let's make sure we're using them in the right population that are really going to benefit. So that's exciting to come away with. And the amazing statistics, 7 in 10 cancer patients will survive for more than 5 years after their diagnosis. So really starting to shift into quality of life life choices because cancer is so survivable now. Quality of life really does need to matter. Okay. And there is talk about a randomized placebo-controlled trial out of England. It's called the Meno ABC trial, looking at hormones after breast cancer. I don't have more information on that right now. When I have it, I will share it. I don't think they're currently enrolling, but I have to look into it more. But like we've said, like we need a randomized placebo-controlled trial looking at systemic hormones after breast cancer, and it looks like there might be something happening in England. So that's very exciting. Reviewed premature ovarian insufficiency is menopause less than age 40, which is 3.5% of all women. Early menopause, again, less than age 45. Premature ovarian insufficiency and sexual function is multifactorial. They can have genital pain from GSM, and they have hypoactive sexual desire disorder. What I found a lot at Ishwish, and I think this is just in general, but it kind of came out to me at Ishwish, that like one woman's experience is not all women's experience, which sounds so simple when I say it. But like a woman will be, for example, a woman will be like, well, I don't have vaginal dryness after menopause, so I don't see what the big deal is. Or like, I didn't have hot flashes with menopause, so like, what are you guys making a big deal about? And always remembering like one woman's experience is not all women's experiences. And I think people, of course, we're all egotistical beings, but like people take that and then they like extrapolate onto all the humans of like how they should live their life because of your lived experience. I think that's really about it. I mean, we're at 40 minutes. That's Ishwish 2026. I love you all. I love giving it. This is probably, I'm trying to remember, this is probably my second or third Ishwish review now on this podcast because this podcast is in year 7. And I tend to go to conferences like every other year, but Ishwish 2027's in Vancouver, so obviously I'm going to go. So I will see you guys there, February 2027. If you want to see where I am going to be speaking this year, if you go to my website, I have an events page. You can check that down. So nice to chat with you all, just one-on-one. Let me know if you want more solo episodes of the You Are Not Broken podcast. I'm here for you. I love you. And I know this was a fast rundown of like my key awesome takeaways. And I literally probably left out like 70% of the conference. But those were just some interesting facts that I thought I'd take down. All right, guys. I love you. Until next time, you are not broken. Thanks for being here. Share with your friends.